Okay, so starting with acute osteomyelitis, and as the name suggests, it is the involvement of bone. Myelo is marrow, and itis is inflammation. And acute means presenting within a short period of time. So acute osteomyelitis. Now, in a long bone, I think all of you must be knowing the different parts of a long bone. So this is, say, diaphysis or shaft. This is epiphysis, and then the extended or expanded portion is metaphysis. Now, this acute osteomyelitis is an entity which is seen in children's. So here there is an additional landmark, and that is physis, or what you call growth plate, right? So this is in a child. Now, this expanded portion is the site of acute osteomyelitis. So earliest site, or most common site of primary osteomyelitis is metaphysis. Clear? So metaphysis is the primary or the most common site of acute osteomyelitis, and there are certain reasons for this. Number one, because this metaphysis is the growing zone or the highly active zone of the bone, right? So this is highly active region of the bone, and there is a characteristic arrangement of blood vessels. We call it hairpin arrangement, right? So hairpin arrangement is something like this, right? So we have, okay, so this is the hairpin arrangement kind of blood vessels, and this gives opportunity for the bacteria to move out of the blood vessels. So this is one important thing. And number two, since this is the highly active zone or the growing zone, so the defense mechanism is slightly poor, right? So this defense mechanism is slightly poor. So these are the few factors why the bacteria prefers metaphysis as the site of primary infection. And yes, in general population, this is usually caused by Staphylococcus aureus, which is an organism of high virulence, right? So this is highly virulent. Now, the word virulent means the capacity to cause disease. Okay, so in general population, this is Staphylococcus, but yes, in cases of sickle cell anemia, this is caused by Salmonella typhi, right? So here you need to remember Salmonella typhi. Clear? So just a special mention in patients of sickle cell anemia. Okay. Now, in body, the most common site is lower thigh, or you can say lower femur, or you can say around the knee joint. Okay, so this is commonly seen around the knee joint, especially affecting the lower femur. And the usual type of osteomyelitis which we see in clinical practice is actually the one which is occurring as a primary infection. So, and this primary type of osteomyelitis occurs when the bacterium is somewhere else, and by the way of blood route it reaches the bone. So that is primary type of osteomyelitis. Sometimes what happens, the fractures, they are having a wound, and they are known as open or compound fractures. Like normally, whenever there is a fracture, most of the time the skin continuity is intact. But sometimes what happens, suppose if there is a fracture, something like this, then there is possibility that there is a wound over the skin on one side, and this wound actually gives entry to the bacterium inside the body towards the fracture site, and this is one of the reason of osteomyelitis in open or compound fractures, right? So open or compound fractures are those which have a wound and the fracture site communicates with the external environment. So that is open or compound fractures, and therefore it is always said that never do open reduction internal fixation in open or compound fractures, because if you put any implant internally, the possibility is that if there is any infection, then it becomes very difficult to treat, right? So never do, or if in open or compound fractures. In older time, when there was very poor method of asepsis while doing surgical procedures, and that also was an method of introducing the infection inside the body. So bony unsterile surgical procedures. This is in older times when there was no proper concept of sterilization, and at times the implants were not sterilized properly, and if we use such kind of implants, then the high possibility is that the infection might set in and the patient can develop osteomyelitis. So in older times, many surgeons, they are very scared of doing operative procedures because they know without proper sterilization they might land up in this complication, right? But nowadays we have very good techniques of sterilization, and this surgically induced infection is not the case nowadays. It's not seen nowadays, right? Now, in children's, the most common type is primary. Clear? It means there is infection somewhere, and from that infective foci, the organism, the Staphylococcus aureus, it will gain access to the blood vessel, and then by the way of blood vessels, it will reach up to the metaphysis. So this is hematogenous. Hematogenous means blood borne. Okay. Now, one problem is that usually in orthopedics, most of the time we rely on X-rays like fractures or some other infections, but especially or even tumors, we can get some hint from X-rays. But in case of acute osteomyelitis, X-rays are normal. So early X-rays may be normal, and therefore we have to always think of the possibility of acute osteomyelitis in a clinical manner, right? So most of the time we always say that diagnosis of acute osteomyelitis is always based on clinical suspicion, right? So based on clinical suspicion, it means if we see a child of somewhere of the age group of 10 to 15 years who is presenting to us with pain, swelling around the knee joint, with high grade fever, this might alert you towards the possibility of acute osteomyelitis. So just based on the symptoms alone, you have to think that this might be a case of acute osteomyelitis, because if you go for X-ray, the possibility is there in early stage of acute osteomyelitis you won't find any particular findings in the X-ray. So if you totally rely on X-ray, you might be misled and you will miss the diagnosis. And in case of acute osteomyelitis, we have to be very vigilant in making a, not only in making a diagnosis, we have to be very active in starting the treatment as well, because this is a very you can say severe infection caused by Staphylococcus aureus, which is a very virulent organism. So we need to initiate the therapy at the earliest using the broad spectrum antibiotics by IV route, right? So therefore the first step is to get up to the diagnosis, and that is the clinical features are sufficient enough for us to believe that yes, this is a case of acute osteomyelitis, right? Now we can do certain investigation, and one of the investigation is blood culture. So what we can do, we can grow the organism from the blood sample, and at the same time we can also do sensitivity, right? So take a blood sample, send it for culture and sensitivity. So culture will show you the organism, that is Staphylococcus aureus, and sensitivity will tell you that this organism is sensitive to which antibiotics, because nowadays the concept of resistance to antibiotics is emerging. So therefore, if you are using any antibiotics from your side to which the organism is resistant, it is not going to respond at all. So if we are sending a blood sample for culture, in the same sitting do the sensitivity as well, and this will guide you like as to use which antibiotic so that this organism is killed, right? So culture and sensitivity. But again, this is not 100% supportive. It can give you some positive results in about 60 to 70% of cases only, but still it should be sent, right? So blood culture we can do. And the earliest radiological sign which we can see in a case of acute osteomyelitis is periosteal reaction. So we can see a periosteal reaction, which is actually reactive new bone formation because of this inflammatory insult, and this takes nearly around a minimum of 10 days, right? So it usually comes after 10 days, and therefore we are never we are not getting any sort of help from radiology in reaching up to a diagnosis, right? So we don't rely on x-ray thing. And yes, we can go for bone scintigraphy because there is infective pathology, so it will show high activity in the form of increased uptake of the radioactive substance. We can also go for MRI. So this is, you can see the high activity is shown by these spots, right? So high activity areas can be seen, and MRI is also very valuable. So we can go for MRI, and it can detect the changes within 48 hours, and therefore we considered MRI as the investigation of choice. Clear? So every investigation has its own benefit. Imran bhai, good afternoon, thank you. So every investigation has its own merit. MRI can help you in reaching up to a diagnosis, but culture sensitivity will tell you that which organism is it and to which antibiotic will it respond, right? We can go for scintigraphy as well. Now, the important part of acute osteomyelitis in clinical practice is management, right? So management is very important here, and as soon as we get the patient, we have to start intravenous broad spectrum antibiotics, right? So intravenous broad spectrum, because we don't know which organism is this, to which antibiotic it will respond. So as soon as the patient comes to us, if the patient comes to us within 48 hours, we will presume that there is infection only, there is no pus formation. So what we can do, we will start the patient on IV broad spectrum antibiotics. At the same time, just before starting this, we will take the blood sample for culture and sensitivity. And once this sample is taken, after that we will start the antibiotics, right? So first step is, of course, the first step is a clinical diagnosis, right? So you can write clinical diagnosis. This is the first step, and the points which you need to entertain here are child, you can say 10 to 15 years, right? Then pain, swelling around knee, okay, or lower thigh, you can say. But more importantly, high grade fever. This high grade fever tells us that yes, there is some infective pathology which is caused by a highly virulent organism. So the first step is you have to make a clinical diagnosis. Then the second thing is that you have to take the blood sample for culture and sensitivity. And once you have taken the sample, third step is you start IV broad spectrum antibiotic. Now fourth step is, once you get the blood culture sensitivity report, right? So once you get this report, once we get the report, we will come to know that what organism it is and what antibiotic is needed to control it. So we will change the antibiotic as per report, right? So it is always better to give only that antibiotic to which the organism will respond. Otherwise, empirically we can start broad spectrum, but yes, if we have the report with us, why to go here and there? Better start the antibiotic to which the organism is highly sensitive, right? So this is the treatment plan. Now this is effective only within the first 48 hours. If the patient presents late, there is high possibility that pus will form inside the metaphysis. And there is a surgical rule related to pus that if a pus is formed once, it always needs surgical drainage. Clear? A pus cannot be treated by antibiotics. It has to be removed from the site. So we need to do incision and drainage. So surgical drainage is needed for the pus. Right? So this is the treatment plan within 48 hours. And if the patient does not respond to antibiotics, it means pus has formed. Right? So we have two conditions where the patient will not respond. If the patient presents after 48 hours, then he will not respond. And in some cases, if patient has reported to us within 48 hours, but still the infection is not controlled by antibiotics, and the only reason is that pus has formed. And once a pus has formed, you need to do surgical drainage for pus, and of course we need to continue antibiotics also. So surgical drainage plus IV antibiotics. So if pus is formed, then we have to include some surgical procedure as well. And if there is no pus, then obviously the antibiotic therapy will work, right? Now, the most common complication of acute osteomyelitis is that it will go into chronic stage. So it can go into chronic osteomyelitis. Now, this condition is very difficult to treat, and therefore we always stress, please make sure that acute is treated properly. There should be no concept of chronic, because once the patient goes into chronic osteomyelitis, The treatment is very long, at times very frustrating, without any result. So the effort should be always to control acute osteomyelitis and let it not go into a state of chronic osteomyelitis, right? Now, other complications might be seen with acute osteomyelitis. Because of the pathology, sometimes the bone is weakened and it can fracture. So such fractures are known as pathological fracture, right? I think all of you must be knowing the definition of pathological fracture. If a bone is weakened by a disease process to such an extent that even a minor injury is sufficient to cause fracture. Otherwise, the bone is so hard, we need a high velocity trauma or high velocity assault to fracture it. But sometimes, if the bone is weak enough, it can fracture very easily. And the classical examples of pathological fracture includes osteoporosis, where we see fractures in the elderly with minor injuries like twisting of lower limb, and the patient might have neck or femur fracture. So that is pathological fracture anyway. Now, there is one complication, that is acute septic arthritis. Now, this word septic means pyogenic. Okay, so septic arthritis. Now, when we use the word arthro stands for joint, and itis is, I think you must be knowing by now, itis is inflammation. Right? Now here we need to understand this particular complication, we again need to go back to the anatomy. And here, suppose if this is another bone here, somewhere here, so we need to understand the anatomy of the joint capsule. If the joint capsule is something like this, right, this is the joint capsule, right, and then this is again the physis here. Now in this case, the infection cannot cross physis, right? So if the metaphysis is extracapsular, here it is extracapsular, means outside the territory of the attachment of capsule. In these cases, the infection will never reach joint space because it cannot come from outside, it cannot cross the growth plate because growth plate is resistant to infection, any infection. So extracapsular metaphysis will never have septic arthritis as a complication because the bacterium will never get access to the joint space. This is the joint space, okay? So it will never get access to the intracapsular space, which includes the joint space as well. Now take another example. I'm just explaining for this point only. Now take another example. Suppose if this is another area where the suppose this is the growth plate, okay, right, and in areas where the metaphysis is intracapsular, right, so this is the capsule, this is of course the physis or the growth plate. Now here the metaphysis is intracapsular, so this is metaphysis, and metaphysis here is intracapsular, means it is within the capsule of the joint. So now what will happen, the bacterium from here, it can perforate the cortex and it can come to lie within the joint. So in case of intracapsular metaphysis, right, this is intracapsular metaphysis, we will have septic arthritis. Clear? So septic arthritis will be seen only if the metaphysis is intracapsular, because the organism cannot perforate through the growth plate. It can only perforate the cortex, and then only it can reach the joint space. So this particular statement should be remembered for intra-articular. This is very important here. And where we see intra-articular metaphysis, especially in hip joint. So in case of osteomyelitis affecting the proximal femur, there will be septic arthritis of hip. And what is the reason? The reason is that the metaphysis is intracapsular. So the bacteria, once it erodes the bone, will involve the joint space as well. Bacteria can never erode the, or it can never perforate the growth plate. This is resistant. The only way it can come through the inside the joint is only possible if the metaphysis is intracapsular, and by breaking the cortex, the bacterium can get access to the joint space. So this point is very important, and very specifically it should be remembered for intracapsular metaphysis, right? And thirdly, again we are seeing here the metaphysis is related to growth plate, and growth plate is responsible for longitudinal increase in the size of bone. So at times the growth plate might be affected, and this might lead to hampering or interfering with the longitudinal growth. So what will happen? To this side, there is possibility that growth plate is affected, so longitudinal growth will stop, but other side will continue to grow normally. So suppose if this is left lower limb, so left lower limb will remain shorter as compared to right lower limb, which will continue to grow normally. So there is growth plate disturbances. And what is growth plate? That is again physis. And this may manifest as limb length discrepancy. Discrepancy means unequalness. One normal limb will be lengthier, the affected limb may remain shorter. So this is limb length discrepancy. So this is acute osteomyelitis. Now the most problematic condition is chronic osteomyelitis, and at times we have already discussed that it can be because of a complication of primary osteomyelitis, right? Or it can be because of unsterile orthopedic surgeries, right? Or internal, or if open reduction, internal fixation for compound fractures. So always and always we tell that please don't do any internal fixation for open or compound fractures, but some people they try, but the rule is that never do any open reduction, right, or internal fixation. And again, since acute osteomyelitis is involving the lower end of femur, so most common site of chronic osteomyelitis is also lower end of femur. Now there is a classical and you can say 100% indicative feature, because what will happen when there is chronic osteomyelitis, there will be formation of sequestrum, which is actually dead piece of bone. Now whenever there is dead piece of bone, body will not keep it inside itself, so it will try to extrude it. It will try to throw it out of the body, and this goes out through sinus, which are actually the openings in the tract in the skin and openings on the skin surface. So at times patient comes to us and he will tell that there is bony pieces extrusion from skin wound. So the moment the patient tells you that I have skin wounds through which small bony spicules come out, that is 100% indicative of chronic osteomyelitis. So these bony pieces are actually sequestrum, and this skin wound is actually sinus. So this is sequestrum and these are sinus, right? So this is the classical feature. So bony pieces coming out through the sinus, that is 100% diagnostic for chronic osteomyelitis. And there might be irregularity of the bony surface. If you feel any of your bone, you always feel that it is quite smooth, but here the bony surface will become irregular, and that is because of the formation of involucrum, right? And there is stiffness of the adjacent joint. It means the movement of the nearby joints will be decreased. Suppose if it is involving the lower end of femur, then the movement at the knee joint will be reduced. So stiffness of adjacent joint. Now, what is more important in chronic osteomyelitis from exam point of view are the radiological features, and every student should be well versed with these terms, because in one or other way 100% questions is framed from this segment, right? So one of the thing which we have already discussed is sequestrum. So sequestrum, we discussed that these are bony pieces which comes out through the bony, which comes out through the sinus in the skin. So these sequestrum are the dead piece of bone, right? So this you have to understand. It is a dead piece of bone, and if you ever look in an X-ray, so if you look initially, there will be a black area, something like this. So there will be a black area, and in that black area you will see small white shadows, right? So there is black area, and in that we can see small white shadows. So this black area is infective granulation tissue, right? So this is in black, and inside that black you will see white shadows. These white shadows are sequestrum, right? So very easy to identify on X-ray. You will see a black area, and within that black area you will be able to see very faint white shadows, right? So these white shadows are sequestrum. So very easy to identify. Okay, you have to see a black cavity, that is infective granulation tissue, and within that you will see a very minute white shadows, that is sequestrum. Now, when a portion of the bone dies, body tries to make up the loss by producing new bone. So that new bone is known as involucrum, right? So involucrum is the new bone which is formed by the body in an attempt to make up the loss which have occurred because of sequestrum. So if you see the dense white area, now if you see here, this all whiteness is involucrum. Okay, so this is all we will call it sclerotic, so means more white on X-ray. Okay, so it is overlying the sequestrum especially. So if you see the white area, this is all involucrum. Okay, and it is just trying to give strength to that area which has now become weakened because of formation of sequestrum. And sinus, I think most of you will understand that these sinus are actually in the skin, and in the bone the openings are known as cloacae, right? So what happens, there are openings in the bone, and through these openings the sequestrum will come out, and finally through the openings in the skin, this is sinus, and finally through this sinus the piece of bone will be extruded out, right? So sinus are opening in the skin, and cloacae are the opening in bone through which the necrotic material or the sequestrum is discharged out. So you have to be very well versed with these four terms: sequestrum, involucrum, cloacae, and sinus, right? So this is very important. And now this chronic osteomyelitis, since it is involving the bone, it cannot be purely controlled by antibiotics, although we need some antibiotic support, but always and always we have to do some surgical procedure, right? So we can do one thing: if sequestrum has formed and the body has not discharged it, we can remove it surgically. So that surgery is known as sequestrectomy. I think ectomy means, all of you must be knowing what does ectomy means. Ectomy means surgical removal. So we are doing some surgical process and we are removing something here. In relation to this, we are removing what? We are removing sequestrum. Clear? It is dead piece of bone, so we have to remove it. Then sometimes what we can do a saucerization surgery. Now what happens at times, if suppose this is the bone, if the bone something like this, there is possibility that the infective material will lie and it will pent up here, it will accumulate here. So what we need to do, we need to convert this area into a saucer. So what we will do, we will make it a saucer. And what will happen now here, the organism cannot stay, it will flow out, right? So this is known as saucerization. So we just want to make sure that there is no some space where the infective material or the necrotic material can accumulate, right? So we'll just convert it into a slope kind of area, so that everything flows out by itself, it does not accumulate at one place. So this is known as saucerization. And third, when you do any surgery, you have to give a continuous suction irrigation, right? So we flow a antibiotic and detergent solution through the bone, and this will clear all the infective material. So suction irrigation, drainage. Clear? And there is one more procedure which we can do. We can put antibiotic impregnated beads, right? So what we will do, we will take a wire, and on that wire we will put some cement beads, and in these beads are prepared by mixing them with gentamicin solution. So what will happen, when we will put this bead inside a bone, so suppose if this is the bone something like this, the antibiotic will be liberated from these beads in the local area, and this will deliver the antibiotic in the area where we have kept this beads, right? So this is antibiotic impregnated beads, and usually we prefer amino glycosides like gentamicin. Clear? So this is just a treatment modality. Now this is very problematic case, and we just try to avoid it, but unfortunately it cannot be. Now what complications can occur? Obviously one thing is that the bone structure has weakened because of the formation of sequestrum, and as I already told you that if a bone is weakened by a disease process to such an extent that even a minor injury can fracture it, that will be known as pathological fracture, right? So pathological fracture can be seen. Then it is a long-standing infection, so it can lead to secondary amyloidosis, right? I think most of you must have read in pathology about AA protein of secondary amyloidosis. And third is that this sinus can undergo malignancy, so that is squamous cell malignancy. So squamous cell carcinoma of sinus, right? So these are few important complications which you should remember and which are very important from exam point of view. Now we move onward to tuberculosis of spine, which is also known as Pott's spine, right? So this is also known as Pott's spine or tubercular spondylitis. Now this is also known as Pott's disease. Now you must have seen many, especially in rural areas, somewhere in the villages, you can see some persons with a kyphotic deformity at the back. So this is actually a healed tubercular lesion, right? So this is because of healed Pott's spine. Now the most common site of skeletal tuberculosis is of course vertebra, right? And here in body, first is lungs in terms of sites of tuberculosis. First is lungs, second is lymph nodes. So what can happen from here? The bacteria can reach by the way of blood vessels, it can reach the vertebra. So in orthopedics, the most common site of tuberculosis is spine or vertebral region. Okay, so skeletal tuberculosis is the most common type of tuberculosis, right? So this is extrapulmonary, or you can say extra nodal, most common type of tuberculosis, right? And this is because of hematogenous route, right? So this is hematogenous route, and the primaries may be in lungs or lymph nodes. By the way of blood vessels, each reaches to vertebra. So this is already we have discussed, and the vertebral plexus is actually the Bateson's plexus. So this is Bateson's plexus, the paravertebral Bateson's plexus. Now in tuberculosis, the most common region is thoracolumbar. When I say thoracolumbar, so it can be, from thoracic 9 to L1. So this is the usually involved segment, right? So in this image, you can see there is involvement of D10, this is D11, and then D12, right? So usually this area is commonly involved in vertebral tuberculosis. And earliest symptom, I think most of you must be knowing what is a symptom. Symptom is what the patient tells us, right? Or in simpler word, patient's complaints. Clear? So this is backache. So if you see any person who is having backache since long and it is not responding to the usual treatment, then think of tuberculosis at least once, right? So this can be the presentation for tuberculosis many times. Then obviously, if there is infection, the surrounding muscles go into a state of spasm, and that leads to stiffness, right? So this is again very early symptom, and this is because of spasm of paravertebral muscles, right? Because whenever there is infection anywhere, the muscles surrounding that region, they will go into a state of spasm. Spasm means they will become little hard, and they will try to make sure that there is no movement around that area, because movement produces pain. So spasm will restrict movements, and these movements will avoid pain. So this is actually a adaptation, or just a method of the body adapted to avoid pain which comes because of movement in that area. Now when there is destruction of the vertebrae, we can see bony deformity, right? So we can see bony deformity like this. So it can be gibbous, or it can be kyphus. So there is obvious deformity, right? So we can clearly see a deformity here. So gibbous or kyphus. Then tubercular infections are always associated with cold abscess. Now when we say cold abscess, they lack redness, pain, raised temperature. Now these all features are present in abscess, right? Now here abscess is there, but it is lacking all these features, and therefore we have used the word cold abscess, because this is sometimes known as hot abscess. Okay, so that is the difference of hot and cold abscess. Hot abscess is the one which we usually see in clinical practice, caused by staphylococcus, right? So you must have seen boil or abscess formation. So here abscess formation is there, but the patient will have no redness, no pain, temperature is normal. So we have given the word cold abscess. So cold abscess has to be remembered for tuberculosis of spine. Then if there is too much of destruction, and the necrotic material will go backward and it will impinge over the spinal cord. So if you see here, this is the spinal cord going downward. So at times there may be pressure by this necrotic material, and then it can lead to injury to spinal cord, and patient may develop paralysis of both the lower limbs. So that is known as paraplegia, right? Plegia means paralysis. So plegia is paralysis, and here it is both lower limbs. Clear? So paraplegia is an indication that the disease has advanced too much, and there is so much of necrotic material that it is impinging upon the spinal cord and injuring it. Now coming to the clinical findings. Patient, we already discussed that there is a spasm of paravertebral muscles. So what will happen? The back will become stiff, and therefore when you tell the patient to walk, he will walk in such a manner that there is less movement of the trunk, and that is known as military gait, right? If you have seen army persons doing march past, you must have seen that they walk in a very stiff manner. Only the hand and lower limbs move, the trunk and the head does not move. So similarly the child will move, but it is not just because he is preparing for army. It is just because of there is infection, the muscles has gone into a spasm, and there is no movement in the trunk at all. So this is military gait. Now what is gait? Gait is actually style of walking, right? So gait means style of walking. So this is military gait, because the person, usually a child, he wants to avoid any sort of jerk on the spine, because the moment there is jerk, there will be a lot of pain. So this is military gait. Then in dorsal spine we can see a kyphus or gibbous deformity. Clear? And for tuberculosis, please remember the word cold abscess, which is seen as a paravertebral swelling. Now, para means by the side. Clear? And not only by the side of the vertebral column, sometimes this cold abscess follows the path of least resistance. This cold abscess will not stay at one place most of the time. It has a habit to trickle down. So what will happen? It will follow the path of least resistance. This is usually the neurovascular bundle, and therefore the abscess will be seen at a distant location than the site of pathology. Right? So what I mean to say that the pathology is in the vertebral column, but you can see that the abscess is present in the psoas sheath, that is known as psoas abscess. So psoas muscle has no pathology. It is just that the cold abscess which has formed within the vertebral region, it has trickled down and it can present at a distant, unrelated location. So one should keep the possibility of Pott's spine. Right? Now, what we can see on X-ray. Now, what happens here? To understand the X-ray changes, you need to understand the type of vertebral tuberculosis first. So, suppose if this is one vertebra, this is another vertebra, and in between the two vertebrae, we know that there is intervertebral disc. Okay, so this is all intervertebral disc, right? This is vertebra, of course. Now the arterial supply is quite unique here. Unique in the sense that the arterial blood supply is not 1:1. It is not like this. Okay, the arterial supply is like this. A vessel will come, it will supply the lower half of upper vertebra, it will supply the intervertebral disc, and it will supply the upper half of lower vertebra. So what I mean to say, that if a bacteria is traveling through this vessel, it is going to involve this much area, right? So it will involve the lower half of upper vertebra, upper half of lower vertebra, and the intervening intervertebral disc space. Now what happens? Because of infection, this disc space will die. And what will happen? The vertebrae, they will come closure. So in an uninvolved vertebra, if we look here, we can see a space, and this space is because of the intervertebral disc. And in X-ray radiological terms, we call it disc space, right? So we call it disc space. Clear? So we will call it disc space. Now what will happen if there is tuberculosis? The disc will die, so the vertebra will come closure, and this is known as reduction in the disc space. Right? So this reduction is occurring because of death of the intervertebral disc, which was creating this gap between the vertebral bodies. Normally they cannot stay apart like this. It is just because of some intervening structure which is not creating an impression on X-ray, right? So that shadow, that black, is actually all disc here, and once the disc dies, the vertebral bodies will come closure, and radiologically we will say that there is reduction in disc space, and this is the earliest radiological finding you will see in a case of Pott's spine. So the moment you see this kind of changes, think of Pott's spine. Now, because of infective pathology, there will be destruction of the vertebral body also. So we will see destruction of vertebral body. So there is destruction of the lower half of upper vertebral body and upper half of lower vertebral body, along with the destruction of the intervening IV disc. Again, you can see cold abscess, and in later stages there might be possibility that the infection might heal, and the infection healing in Pott's spine is by the process of bony ankylosis. So please remember the word bony here. Now this is very important. So both the adjoining vertebrae, they will fuse together and they will become a single vertebra. So bone to bone fusion. Ankylosis means fusion. Clear? So this is the case here. Now here we can see this is all cold abscess. Clear? You can see this is all cold abscess. Most common, we discussed the blood supply. This is the pattern of blood supply, and this type of tuberculosis is known as paradiscal. Para means by the side. Discal is of course disc. So we can see that the vertebral body's area which is surrounding the disc or by the side of the disc are involved, right? So this is paradiscal. So most common type is paradiscal. So this is what we have already discussed. Lower half of upper vertebra, then upper half of lower vertebra, and the intervening disc. This is all have a common arterial supply. Okay. Now sometimes if we see in this diagram, this is the paravertebral variety, right? So lower half of upper vertebra, upper half of lower vertebra, and the intervening disc space also. So this is the paradiscal variety. Okay, this is the paradiscal variety. Now sometimes what happen, the anterior ends may look like something like this. So in cases of anterior type of vertebral tuberculosis, there is erosion of the anterior part of vertebral body, and this is the same finding which we usually see in some other pathology if there is aneurysm of the abdominal aorta. So therefore we call this sign as aneurysmal sign. So this is aortic aneurysm, right? So there is erosion of the anterior part of the vertebral body. Now this is because of tuberculosis here, but it looks like as if there is an aortic aneurysm, so we call it aneurysmal sign, right? Then this, I have already told you, it heals by bony ankylosis, means the two vertebra. Now these were two different vertebrae, right? These were two different vertebrae, but now you can see they have fused in this area. So this is bony ankylosis, bone to bone fusion. Pott's paraplegia, this we have already discussed, that if there is too much of pressure over the spinal cord. Now this black structure is all spinal cord, and you can see here is the tubercular pathology, and the necrotic material is pushing over the spinal cord. Again you can see here this longitudinal structure is all spinal cord, and the pathology is compressing upon the spinal cord, and this will result in paraplegia, that is paralysis of both the lower limbs. So Pott's paraplegia refers to neurological complication commonly seen with dorsal or thoracic spine tuberculosis, especially in the thoracic region, thoracic vertebral region, right? Dorsal vertebra. So this is already we have discussed thoracic or dorsal, and what we need to do here, we need to go for MRI. So MRI will tell us about the amount of compression, any marrow edema or other things, right? So MRI is the investigation of choice. Now what we need to do, now the pathology is compression of spinal cord, right? So there is compression over the spinal cord. So what we need to do, we need to remove this compression, and therefore we will do decompression. So we need to do decompression, and we can do decompression only if we get a route to reach up to that spinal cord region from where we can remove all the necrotic material. So we can do costotransversectomy again. So the word ectomy is coming here. So I think all of you can understand. Now costo word is ribs. Transverse word is actually transverse process. Okay, so this is transverse process of rib. So we will remove the part of rib, the transverse process, that is costotransversectomy, or we can do anterolateral decompression, right? So we can also do a anterolateral decompression. So we will remove part of a rib, we will remove the part of the vertebral body as well. So that is anterolateral decompression, and you can remember the short form ALD. So these are decompression surgeries done to reduce or remove the pressure going over the spinal cord, which is resulting in POTS paraplegia. Now we move forward to tuberculosis of hip joint. Again, this is a very important segment, and we have questions from this topic most of the time. Now here the pathology starts in bone, right, as compared to knee, where the pathology starts in synovium. Clear? So in tuberculosis of hip, the pathology starts in bone. It can be acetabulum, it can be femoral head, but most commonly it is acetabulum. Now here the granulation tissue, which is actually necrotic material also, and it contains the bacilli also, it reaches the joint space of the hip joint after eroding the bone and cartilage, right? So it finally reaches into the joint space. So if you say, if suppose this is the acetabulum, right, then this is, say, the head of femur. Okay, so if the tubercle bacilli is here, right, suppose if there is a tubercle bacilli, it will erode the acetabulum and it will reach the hip joint space. Okay, so this is the usual, this is the capsule, of course. So this is how the granulation tissue will reach to the joint space. So this is all joint space. Okay, so the infection starts in bone, usually acetabulum, and then it erodes the bone to finally reach to the joint space. And again, this commonly affects children's. Now the classical features, the presentation is very characteristic, and that is known as night cries or starting pain. Now what happens in the daytime, because of infective pathology here, there is a spasm of the muscles surrounding the hip joint, and therefore the patient will use the hip joint very less. But what happens when the patient sleeps and the muscle relaxes, as it turns here and there will be rubbing of the bones, and that produces very severe pain. So the child will wake up in the midnight and he will start crying, and he will say that there is very severe pain in my hip joint. This is because during sleep the muscles relax, and the protective spasm which was seen in the daytime is missed here, and therefore the child starts crying. So this is night cries, very specific for TB hip joint. Now at times the pathology is in hip joint, but the patient will come to you and he will say that there is pain in my knee joint. So this is known as the concept of referred pain, and this is because both the joint have a common nerve supply, that is by the obturator nerve, right? So the obturator nerve is supplying both the joints, and therefore there is this concept of referred pain. And again, cold abscess, you have to remember, it can be seen in late stages. Now there are three stages of TB of hip. In earlier stage there is synovitis, and what will happen now here, I think all of you must understand what is synovitis. Itis is again inflammation. So there is inflammation of synovium, and once there is inflammation of synovium, it will produce more of synovial fluid, right? So synovial fluid production is increased, and because of this increased synovial fluid, now the joint capsule is a limited space, so the knee joint will assume a posture in which it can accommodate large number of synovial fluid, and that position is Faber. Clear? So flexion, then abduction and external rotation. Okay, so this is Faber, and because of this Faber, the affected side lower limb will appear lengthier. So if you look from a distance, you will feel as if the limb is lengthier than the normal side, but when you will do measurements, you will find that both the limbs are of same length. So this is known as apparent lengthening. Apparent means it seems. So Faber apparent lengthening. Now what will happen after synovitis? There will be arthritis. So there will be involvement of the joint, and once there is involvement of the joint, the surrounding muscles goes into spasm, right? So they goes into spasm. Now hip joint is surrounded by a lot of muscles. Some are internal rotators, some are external rotators. Very good, Shanavas bhai, Fedir. So some are internal rotators, some are external rotators, some are adductors, some are abductors, some are extensors, some are flexors. Now what will happen? The muscles which are powerful, they will pull the hip joint in their direction, and the powerful muscles are flexors, adductors and internal rotators. So therefore we will see this deformity: flexion, adduction and internal rotation, right? So this deformity is because of the spasm of muscles, and since the flexors are more stronger than extensors, adductors are more stronger than abductors, internal rotators are more stronger than external rotators, so we will have Fadir deformity here. Now if you look from a distance, again there will be a change in the length. So we will feel as if the limb is shortened. The limb will appear shorter than the normal side. But when you will do measurement, again you will find that both the limbs are of same length. So we'll use the word apparent here. So apparent lengthening in first because of Faber, apparent shortening in second stage because of Fadir. Now what will happen in third stage? Now there is actual bone destruction, and when there is actual bone destruction, it means there will be reduction in the size of that lower limb. So there is true shortening because there is destruction of the bone. So this will lead to true shortening, and the deformity of the second stage will continue in the third stage as well. So we will have flexion, we will have adduction, and we will have internal rotation, right? So just remember these three stages. And yes, there is true shortening because there is bone destruction. So the length of the lower limb will become shorter as compared to the uninvolved side, right? So this is already, we have discussed what does the word apparent mean. Lengthening, it means it appears lengthened although the exact length is same as that of the other side. Now what we will see on X-ray? The earliest thing is we can see haziness, which is suggestive of some infective pathology, and as the cartilage goes away, there will be a reduction in the joint space, because the joint space what we see actually, right? So if I, this is normal here, this is normal side, this is affected side, right? So on normal side, suppose this is acetabulum, this is head of femur. So whatever the joint space we are seeing, this is all having articular cartilage here. So there is articular cartilage over the head of femur, and there is articular cartilage over the acetabulum as well. Now when this cartilage will die, the bones will come closure, and that is perceived as reduction in joint space. So this is actually because of degeneration of articular cartilage. Clear? Which is hyaline variety. I think most of you must be knowing this is hyaline variety. Then there might be lytic lesions or irregular outline, right? So this is because of bone destruction. So if we look on the affected side, we can see that the appearance of the bone is so irregular. Okay, so irregular because of bone destruction. And what we can see here, there is wandering acetabulum, right? So what happens, the head of femur, it is destroyed by the infective pathology, and the size of infective this affected head of femur becomes small, and therefore it dislocates and it goes back posteriorly, and over the acetabulum it will make a false articulation that is known as wandering acetabulum, right? And sometimes we can also see a motor pestle appearance. If you have seen that bowl and something to make medicines with those Ayurvedic doctors, so that is mortal and pestle appearance. Okay, so wandering acetabulum is a radiological feature, or you can say traveling acetabulum, right? Chalo. And sometimes there might be fixed flexion deformity, and this is actually done by Thomas test. Now treatment, since there is infective foci within the joint, so we have to clear that, so that is known as debridement. Okay, so we can clean the joint, and sometimes when we see that the head of femur is extremely damaged, we can remove it, and that surgery is known as girdle stone arthroplasty. Okay, so if you see here, there is no neck or head of femur, so we have removed everything from here. So this is the girdle stone arthroplasty. We have removed everything. Okay, so, and yes, very importantly, TB hip heals by fibrous ankylosis. See, TB spine heals by bony ankylosis, and TB hip heals by fibrous ankylosis. So this is very contrasting. Pathology is same, but the outcome is different. And here we can also take one word. If there is septic arthritis, it will also heal by bony ankylosis. So bony ankylosis or bony fusion, it is seen in septic arthritis, number 1, and number 2, TB spine. Clear? And TB of any joint like hip, knee, or any other joint, it will heal by fibrous ankylosis. Clear? So this is enough for this session. I am very sure you must have enjoyed the session. So see you later with some other topics. Goodbye. God bless. And yes, I will shortly share this PDF. I will share the PDF in my app, right? So those who are not on the app, I request them to please download it, and all these PDFs will be unlocked, so you can view them for free. You don't have to pay any charge, right? uh, Thank you, Shanwaz bhai. I'm really happy that you liked the session. See you soon. Bye bye. God bless.